What we'd like to do here is give you a tour of the Maquette Servo I ventilator. This is the ventilator that we happen to use in all of our adult intensive care units here at the medical center. This is a standard setting. We have an artificial lung here, and this is, as you can see, the patient is set on PRVC, pressure regulated volume controlled. The patient is set with an FiO2 of 60%. There's a PEEP of 5 set, and you would change these by dialing the little knobs here up and down. There's a set rate of 15, and the tidal volume is set at exactly 450 milliliters. If you push this button here, this is the standard mode that you'll see on this particular ventilator, and this is telling you what the patient is actually getting. So for example, you can see that the tidal volumes going in are 454 mLs, and the tidal volumes coming back are 458 mLs. These numbers should be very close to each other, and if they're not, something needs to be looked into. Either the patient has a problem with their endotracheal tube balloon, or the patient has some sort of bronchopleural fistula of some kind, where air is leaving the patient, not coming back through the lumen of the endotracheal tube. This is documenting that the patient is still on 60% oxygen, that they're actually getting the oxygen you want them to be getting. And there will be discrepancies here sometimes, for example, when you first make changes to the amount of oxygen that you're requesting as the oxygen blender dials up and down. Here is important, documenting the I to E ratio, and this is normal, the 1:3 ratio in terms of inspiration and exhalation. And this is important. I'm always asking this on rounds. What are we set at and what are we breathing at? Because this is very important. Depending on what the arterial blood gas shows, are we overventilating the patient? Are we underventilating the patient? Are we oversedating the patient? Next, we're going to demonstrate how you do an inspiratory pause to show a plateau pressure. As we've talked about on rounds, the differential diagnosis of patients that have a high peak airway pressure includes those patients that have a high peak airway pressure with a high plateau pressure and those that have a high peak airway pressure with a normal plateau pressure. So my assistant here during the next breath is going to do an inspiratory pause. And you can see that the plateau pressure is 16 and the peak airway pressure was 19. And so the overall is that is particularly, it's remaining elevated. But the point is that neither the peak nor the plateau were abnormal in this particular case. If somebody has a high peak airway pressure and a high plateau pressure, it means the problem is intrinsic either to the lung or to the chest wall. And if it's a high peak airway pressure with a normal plateau pressure, you've taken away flow, and therefore it's problems with airway resistance or somebody's biting on the endotracheal tube. We've now set it up so that the ventilator, with my colleague here, is in pressure support mode. In that mode, the patient is designating and triggering all of the breaths. And you can tell that yourself as the clinician by seeing this little purple uptick, which is the patient triggering event. We'd like to take a few moments here and describe to you what each of these waveforms refers to. This is called the pressure scalar, this is called the flow scalar, and this is called the volume scalar. As you can see, starting from the bottom, with each breath, the volume scalar goes up, and as the patient exhales, it goes back down to 0. The green here showing that with each breath, during inspiration it's positive, and during exhalation it's negative. And it's important that you see that it goes back down to 0, indicating that we don't feel there's any obvious auto-peep. That's an important issue. And this is the pressure scalar, showing that the pressure goes up, and although it does go back down quickly during exhalation, because the PEEP is set at 5, it doesn't go back to 0. This is an example of ventilator dysynchrony. This is an important thing for you to be aware of in the intensive care unit, and there isn't one particular answer. The patient needs to be assessed to make sure that the tube has not been dislodged or does not have mucus plugging, or that the patient isn't in pain or having breath stacking for other reasons. It's very important that the patient be quickly assessed if you see this phenomenon. Here we have a patient on pressure support ventilation during a spontaneous breathing trial. We're watching closely for any evidence of either tachypnea or bradypnea, to see if there's problems where the patient may be failing. As you can see, there are fairly prolonged periods between breaths. This is a sign that the patient may be oversedated or still have residual narcotics on board or sedatives, and you can see that the tidal volumes generated are quite small. This may show this may be a sign of neuromuscular weakness, or again, that the patient has not fully recovered from anesthesia. It's very important to be able to recognize some of these abnormalities on the ventilator. In this particular ventilator, if we wish to do a formal CPAP trial, as you can see here, you set the pressure support to 0 and you keep the PEEP level what you would like. The patient can take breaths at whatever rate they wish. The demand valve is open, and as you can see, the ventilator is doing its best to keep the pressure at the mouth opening at 5 centimeters of water. You can see that there is flow going into and out of the patient, and tidal volumes are being generated, but they're not being particularly generated at a particular tidal volume, nor is a particular pressure set above the PEEP level. This is an example of what the servo eye looks like if you set the patient on pressure control. Again, as I mentioned before, you don't set a tidal volume, you set a pressure control level above a certain PEEP. And here, for example, we're on pressure control 12 over a PEEP of 5 with a total pressure target of 17. The respiratory rate is set and the FiO2 is set. And you set an inspiratory time, which is equivalent to setting an I to E ratio, which you can see here is 1 to 3. But again, this is another fully supported mode. And you would do this, for example, in a patient who had severe acute lung injury where you wanted to not allow the peak and plateau pressures to become very elevated.